Okie doke, artichoke. Look, mixing it up a little bit here.
Whoa.
New episode of the IBS Freedom Podcast coming at you. I'm Nikki. This is Amy. You know who we are by now. This is hardly our first episode. But as always, care to introduce our topic, my darling co-host?
Yeah, so we're talking today a little bit about when you should explore IBD as a potential diagnosis versus just the IBS diagnosis. It was interesting. I looked up a stat today, and I think that they said that about well, this is something different, sorry. But okay, now I messed up the flow. I was looking up stuff about microscopic colitis, not just IBD in general, but I would love to get a stat on the percentage of people that get misdiagnosed as IBS when they actually have IBD.
Yeah.
That would be really an interesting, and you could probably figure that out, I would guess. But, you know, most of the time when people find us, they've sort of been through the testing to rule out things like ulcerative colitis and Crohn's. But there's sometimes a percentage that hasn't ruled that out. Maybe they haven't gone to like the conventional GI docs. Yeah. Those are usually who's going to rule out the IBD scenario.
I think so. Yeah.
And there can be some... Go ahead.
Sorry. And I think it's in part because there's more stuff that you can measure to confirm, or things that you can visualize to confirm Crohn's or colitis or celiac disease, which is not part of IBD, but it's also usually like one of the things that gets checked off the checklist. And then it's like, after you exclude all of those other things and you prove their absence, then it's like, oh, you're left with, you have an irritable bowel, dum-de-dum-de-dum-de-dum-de-dum.
Right.
And that's where a lot of people land at the diagnosis of IBS. So admittedly, a lot of you out there probably have had IBD ruled out at least once in the past by a GI doctor.
Right. And I think that it's interesting. I'd love to hear, do you typically work with people with IBD? Is that like a decent percentage of the people you work with?
I wouldn't say it's a big percentage of what I work with, probably because my YouTube channel and my podcast, and like everything is kind of, I tend to focus a lot more of my time on those channels for IBS and SIBO. So I think I tend to get more inquiries from people with IBS and SIBO. But yeah, I've worked with Crohn's and colitis, ulcerative, collagen, that's always a mouthful, collagenous, and lymphocytic. I've worked with all three types of colitis before as well.
Yeah.
How about you?
Yeah, it's typically not something, like if someone has a lot of flare-ups of Crohn's, ulcerative colitis, usually I will refer them out. I kind of specifically, like I might screen for that if I felt like someone hadn't been screened for it and they had some symptoms, but I typically try to avoid working with people, especially if they have moderate to severe disease from a Crohn's to ulcerative colitis standpoint, just because there's a different degree of variables present. But again, it'll be interesting hearing your perspective. I've had a number of people, and that's why I was bringing up microscopic colitis. So it's something that's not always super obvious on testing, and you have to sort of do histological or look at tissue under a microscope to really see if it's present. I've had a couple cases where they've had really they've had microscopic colitis and it went undiagnosed for a period of time. Like it was missed. So I do think that that's a percentage. There was an interesting study that I looked up to. It was 247 people that were diagnosed with IBS, and 6% had microscopic colitis. And again, another stat within that particular paper was saying that a third of microscopic colitis cases get missed on their first exam because it's something you can't see. And again, maybe they take some culture or something, or they take some tissue, and it's not necessarily in the area that has the colitis at that time. So it can be a little bit tricky if it's something that you can't really see as prominently as like an outright ulcerative colitis or Crohn's case.
Yeah. Yeah, and that's a good point, is that I do think that those folks get missed a bit more. And they're kind of different processes involved too. Like, it seems like irritable bowel syndrome and SIBO kind of clump together really nicely. Often, not always, but 60-70% of the time, people who have IBS in fact have SIBO. And then that suggests that for the majority of people with IBS, the problem is largely in the small bowel.
Right.
Although, like we've talked about on this podcast before, virtually all of those people also have dysbiosis of the colon.
Right.
So it's not to say that we're just disregarding the microbiome in the colon entirely, or the physiology outside of the small intestine, but it's like kind of the primary focus and where most of the dysfunction is going to be in the small intestine. And then we're looking at how other systems and other tissues influence the small intestine, right? So like, we don't think that the chief problem for people with SIBO is the microbiome in the colon, but how the microbiome in the colon influences inflammation and the nervous system, and therefore influences the environment in the small intestine and nervous system control of motility. Like, that's huge. But it's not that the primary problem is in the colon for those people. It's that we're looking at that as something that's from kind of the outside influencing the small bowel. So it's a little different versus Crohn's. And we'll start to kind of get into some of the differences. Crohn's can affect anywhere in the GI tract.
Right.
Esophagus, all the way down to the colon. A lot of times the lesions are going to be in the small intestine or the colon. So that's Crohn's is kind of the crapshoot in that way, because it can be kind of anywhere. And then ulcerative colitis is going to be affecting the colon, thus the name colitis. So you have this kind of like segmented view. Is like, if it's primarily small bowel, then I'd be thinking a little bit more SIBO, IBS kind of stuff. If it's only colon, I'd be thinking more colitis. And if it's all over the place, kind of a crapshoot, and it's a patchwork of dysfunction and lesions, that we're probably looking at more of a Crohn's diagnosis.
Yeah, and I think that, like, I like that you're differentiating between, like, IBS and IBD generally. I think that there's just such a higher degree. There can be some inflammation in IBS, but the inflammation to the tissue is way more intense with ulcerative colitis and Crohn's, and you have this huge immune component because they're autoimmune diseases. And I know sometimes people mess up the names, where they'll say like inflammatory bowel syndrome instead of irritable bowel syndrome, or like inflammatory, or they'll say irritable, or I guess they wouldn't say irritable bowel disease, but sometimes people mix it up. But I think the name's really clear that there's definitely going to be way more of a deep-seated inflammatory immune system problem with Crohn's and ulcerative colitis that is not present with IBS due to the autoimmune nature of the disease.
Yeah, and that's one of the things that I think you kind of alluded to this before when you were saying that your preference is to not work with IBD. And maybe part of the reason why, and not to assume things and put words in your mouth, but it might be because IBD can be much higher risk. Like, flare-up of SIBO, don't get me wrong, a flare-up of SIBO is miserable and you're going to feel like crap, you're going to blow it up and feel 9 months pregnant, but it's not going to be life-threatening, typically, versus a really nasty flare-up of Crohn's or colitis could potentially be life-threatening, or it could require emergency surgery where they take out part of the colon or part of the small bowel. And that's really high-stakes, scary stuff.
Yeah, and I think there's a degree of collaborative care that has to be present. Like, I almost think sometimes people with Crohn's and ulcerative colitis, like, you want to be working closely with a team in those situations, or at least, like, I would feel better if I had close connection with their doctor and could kind of go back and forth at least somewhat. Agreed. And have an understanding of what, like, the mutual goals are. And I think, again, like, a lot of my clients are coming to me wanting just primarily to work with me. And maybe I'm very collaborative in nature, like if their doctor wants to collaborate with me. But I think there's a degree of what you're saying. It's higher risk. I think having a collaborative care team makes sense to me. And just the span of different areas that I'm working in makes it harder to have like a person that a GI doc that's referring me or something that we could work together. Mm-hmm. It's interesting too, because whenever I think of IBD, and this is just what comes to mind to me often, was when I had my FMT done. So the fecal microbiota transplant place, they do a lot of work with IBD. But the interesting thing about that is that they sort of take a totally different approach. Not like totally different, but they're much more careful about when they implement the FMT compared to when they do it with someone with IBS. And they talk...
what sense? Like...
So like they will talk about how they'll have someone with Crohn's or ulcerative colitis that comes in and they schedule their appointment. And, like, let's say the person comes in and they feel like they're in a little bit of a flare. They would not have them do FMT at that point in time because the microbes affect the immune system in such a big way that sometimes it can amplify the immune response. So,
that makes sense.
And again, when I went through the process of them seeing if I was a good candidate or, like, what factors are at play that would make me a good candidate, I was a really good candidate because I didn't have that outright inflammation. And it's not that you couldn't do FMT and that it couldn't be helpful, but they said, if we're going to do FMT for someone with Crohn's and ulcerative colitis, we want them to have no flares at all in this particular moment. We want things to be suppressed. And we can usually get good results, but only if the immune system is suppressed enough to a point where they can make progress, where it's not going to amp things up more. Yeah. And I think there's an aspect of that's really, in my head, the key difference between the care is there has to be such a strong degree of inflammation reduction in the IBD group. And it's not to say IBS doesn't have some inflammatory aspects to it, but it's not it might not be inflaming really intensely the local tissue like IBD does.
Yeah, and that's such a good point to acknowledge, too, because that actually segues into one of the things that I want to point out, which is testing. So, like, for example, fecal calprotectin is sometimes, like, a really easy, non-invasive initial kind of marker that can tip you off to the possibility of inflammatory bowel disease. It's not to say that calprotectin can't be elevated if you have IBS or SIBO. I actually saw a study, I think it was in 2020, where they did show that people with SIBO have elevated calprotectin a lot of the time, but it's going to be like, it's going to be a difference of like 10% out of the range versus 10-fold out of the range. That's kind of what you're looking at with calprotectin. So if you say, and I don't know what the range is off the top of my head, but if the standard range for calprotectin, as an example, goes up to 300, if you're like in the 300s, you're probably looking at more of like an IBS, SIBO, dysbiosis kind of scenario. If, again, using those same numbers that I pulled out of absolutely nowhere, I don't remember the range off the top of my head, but if the range goes up to 300 and you get a value back on calprotectin that's like 1,000, you're much more likely to be looking at Crohn's or colitis, and then you want to get further workup, whether that be a colonoscopy, endoscopy, blood work to look at the antibodies, but that could be an initial kind of tip-off. And the other thing I want to say about calprotectin in particular is that I don't know if you've seen this. It makes me mad. And I don't know, like, a better way of going about it than what I currently do. The freaking GI map. I have seen numerous times that they come back and they say calprotectin is elevated, and I have to have a talk with my patient about, hey, this is what it could mean. This is what it likely means. And then I always, when I see that on a GI map, I always do my due diligence because I know as a side note, if you go into your normal GI doctor and you give them a copy of your GI map stool test results, they're going to look at you like you have 3 heads and a squirrel body, and they're going to be like, whatever, lady, like, come back when you have some real tests. They don't trust the GI map, and it's kind of understandable. And that goes for other functional tests as well. They're going to look at you like you're a weirdo, and they're not going to buy it. So in part, knowing that that would happen, and in part wanting to just kind of double check because I don't trust it. When I see elevated calprotectin on the GI map, I will always have the patient do a calprotectin stool test from LabCorp or Quest, one of the normal conventional tests. And literally, so far, I'm batting 100%. Every single time, it comes back normal on LabCorp.
Oh my gosh, it's so funny you bring this up, because literally I had a client in the past 3 months. I've just found the lab. I pulled it up when you were talking. So she had a GI map run. It wasn't through me, it was through another provider. And she again was freaking out because her calprotectin was in the 800s. So she took it back to another provider. It wasn't the same that ordered the test. And this provider said the same thing you did. Let's retest using a more conventional lab. Well, she retests less than a week later, and her numbers is 119. Which again, they sort of, in the LabCorp, it's right on the borderline of being abnormal, but it's not in the 800s.
Yeah. You're not doomed.
Right. It's not like you should go get a colonoscopy right away or get imaging right away. So, and we actually ran an elastase marker as well. Her elastase was pretty low on the GI map, and it was double on the LabCorp map, the LabCorp test.
Yeah, that's less related to IBD, but I've seen that numerous times as well. And I just had one recently come back. Her elastase on the GI map was really scary low. It was 67. I was oh God, that's really, really in rough shape. And I forget what her LabCorp test result came back at, but it was normal. And then I had another one that it was kind of borderline. It was somewhere in the 100s on the GI map for elastase. LabCorp said it was over 500.
Oh my gosh.
It was, it's high enough that LabCorp's whatever. After 500, it's all the same to us. Whatever, it's above 500. So it could have been 8 million. We don't even know. But LabCorp's nah, it's good enough. Over 500.
Right. I wonder about that even personally, because when I run GI maps, my elastase is always not to the point where they label it as low, but it's kind of between maybe 250 and 500 the couple times I've done the GI map. So there's been times I've done, a little bit more high potency pancreatic enzymes just to see how I'd respond, and I get no effect. So to me, I never did the actual go and get it tested at LabCorp. I probably should. It'd be interesting. But yeah,
honestly,
it's
what would be more fascinating, because realistically, when you collect for the GI map, then you have to wait a week and a half or 2 weeks for the results. So even if you got the results and then went right into LabCorp the next day, you're looking at least a 2-week delay. What would be the best is if we had people do it parallel off of the same exact stool test.
Right.
I mean, if anyone wants to volunteer, I don't know. You'll have to pay for the stool test yourself, but that would be deeply fascinating. I've thought about doing that with some patients before, or I might do it on myself as an experiment to do a YouTube video about it. But I have a lot of opinions on the GI map. I don't think it's all bad. I think that there's some parts of that test that are useful, but there's been a lot of suspicious stuff I've seen over the years about the GI map that I do not like. So I don't trust them as far as I can throw them.
Yeah. Yeah, and I wonder too, again, with some of that testing too, if you're doing such a wide swatch of different tests, again, it makes me wonder if that has an effect on accuracy and reliability. I don't know, again.
Maybe.
But versus just doing the elastase test at LabCorp, and then again, having a really comprehensive test where you're looking at a lot of different stuff. I question a little bit of that too. I don't know.
Well, it does make you wonder, because if you do stool testing through LabCorp, a lot of the times they have different vials that need to be used. Because, like, one of them might have a solution that stabilizes the microbes or kills the microbes. Another one might have a solution with, like, a certain pH that modifies something. And it is odd, because, like, the GI map, for example, if I remember correctly, you just collect the one tube. And that's encompassing bacteria, viruses, parasites, yeast, digestive markers, inflammatory markers, the whole kit and caboodle. And it makes you wonder if at least one of those should be a separate tube.
Right.
Anyway,
but I want to say one other thing. One other thing. I also wonder a little bit about, like, the amount of stool you put into the tube. I think there's probably some way to control for that, but, like, I'm not so sure, because this was a while ago, I did the GI map, and my husband did the GI map, and he, like, literally filled this thing to the brim, and, like, again, it has the marker, and I'm like, oh my god, Armand, like, what are you doing? So he filled it to the brim, and I, of course, like, filled it right to the line. Yeah. And I just wonder if that, like, changes the dynamic of the test, too. It's hard to know, but, again, he probably got double the stool into the tube compared to me.
You're making the mental juices flow so much, because I'm so tempted to, like, run an experiment.
Yeah.
And, like, have samples from the same poop. And have one filled to the brim and one, like, right on the line. Yes.
Because I'd have to imagine that changes, like, the amount of stool per, like, solution, and the... I don't know. I've tried to reach out to them about that. I actually think I actually don't think I reached out. I think I was on a webinar or something with Diagnostic Solutions and tried to ask it, and no one answered it. They kind of skipped over my question. So I was like, I don't know, is that suspect? I'm not sure, but I haven't gotten a clear answer. Right. Was that sus, or did they just accidentally skip over it? I don't know.
Yeah. Huh. Well, in either case, the topic of today's episode was not entirely to rag on the GI map, although it is one of my favorite pastimes. And again, it's not that it's an entirely bad test. Like, I do think the first page and the parasite part of the profile are good. The rest of it, I strongly question, which is honestly why most people run the GI map to begin with. So, you know, the rest of it, there's a lot of caveats and asterisks, and I have a whole video on my YouTube channel about the GI map and kind of my beefs with it and what I think is usable and what I think is not. But to go back to inflammatory bowel disease, and may I point out, we've done it again, my darling. In the last episode, I pointed out that we have this habit of getting a good way through the podcast episode before we actually, like, define something or describe something for the audience. So maybe can we backtrack and talk about some of the symptoms of IBD so that people know if they should care about listening to the rest of the podcast?
Yeah, I think that makes sense.
There's...
Go ahead.
Oh, sorry, I was going to say there's... I pulled up a nice little, like, Venn diagram to kind of start us off with.
Awesome.
A nice visual. So again, like we said, Crohn's can be anywhere in the digestive system. Colitis is just in the colon. But some of the things that are in the middle of the Venn diagram that they share in common is abdominal pain, abdominal cramping, and bloody stools. Although bloody stools are going to be more common with ulcerative colitis, and it's usually going to be a more like alarming amount of blood as opposed to Crohn's. But Crohn's could have bloody stools. It's not to say that they can't. And therefore the likelihood of anemia is greater with colitis because I think of that potential for blood loss potentially. According to this particular paper, at least, the abdominal pain is a little bit more common or more prevalent in Crohn's. I don't know if I would agree with that, but sure. Again, rectal bleeding, much more common in ulcerative colitis. And then something that we will talk about in the coming months is colon cancer. And I kind of forgot, honestly, that both of these increase your risk for colon cancer, but ulcerative colitis more profoundly.
Right.
But I think like diarrhea is common with both, but particularly a lot of mucus and a lot of blood in the stool. I would think more ulcerative colitis. If there's a smaller amount of mucus or a small amount of blood, or if it's kind of inconsistent, then I would think a little bit more colitis or Crohn's rather. I remember too, I don't know if this really has a lot of merit to it, but I remember when I was in school, in some textbook that I had, and in lectures, I remember that there was this picture where they basically drew a diagonal line from the right lower rib cage, like near the liver, down to the left lower quadrant, kind of going like this, if you will. And the idea was that more so with colitis, the pain's going to be more on that left side. Because again, it's like the latter part of the colon is on the left side of the body. So the idea was that would be a little bit more common, the location of the pain for ulcerative colitis versus Crohn's, which can be more localized in the small intestine. It's going to be more like on the right side of the abdomen. I don't know if I've seen that widely to be true. I think that at the end of the day, people are just like, I have an abdominal pain, and it's so diffuse that they can't really pinpoint it. But theoretically, that might be useful for somebody to hear that. Again, I haven't checked that reference, and I haven't looked at that book in probably 10 years. But I do remember that visual and thinking that was maybe useful.
Right. Well, and I think there can be one thing, and it could be related to some bile acid diarrhea, but I think there's definitely sometimes a higher urgency for things like Crohn's and ulcerative colitis. I know sometimes like nocturnal type diarrhea can be more kind of common compared to IBS. You could still have that with IBS, but is something that you could think a little bit about in terms of IBD. The other thing too is weight loss, which again can be there sometimes and not others. But I think sometimes when people are losing a lot of weight and they're clearly having outright absorption issues, which I think a lot of people in the IBS space think that they're having absorption, like major absorption issues, when maybe they're not. They could still have some digestive insufficiency of some sort, but not to the degree of which someone with Crohn's might be having. But I think weight loss can be another more common indicator of Crohn's compared to like an IBS situation.
Yeah. Celiac disease too.
Right.
If you haven't really ruled out celiac disease or Crohn's, those are two really big things that will cause blatant malabsorption.
But check your calories first too, because
thank you. You took the words out of my mouth. Yeah, like don't. Honest to God, Amy, we have to do a whole episode about malabsorption in the future, and like how you can like diagnose it and rule it in, rule it out. Honestly, in my kind of world, at least, I would say a solid 80% of my patients who have IBS and SIBO come in and they either mention malabsorption, they were told they had malabsorption, usually by a functional doctor or somebody who's not in the conventional space, or they strongly suspect that they have malabsorption and they're convinced. And then most frequently what I'm finding is that, when you check the calories, it turns out they're not eating enough calories, or, sometimes people will say like, oh, I have malabsorption because I have low B12 or low vitamin D, like I can't absorb it. And it's like, okay, but is it the quality of the supplement that you're taking? Like if you're taking like a crappy Centrum multivitamin, I got nothing for you. You might just need to switch brands.
Right.
And like I just talked to somebody about this earlier this week. She started on hormonal birth control pills. Well, hormonal birth control depletes you of everything.
Right.
But namely the B vitamins and minerals like zinc, magnesium, and calcium. And I forget if iron is depleted with hormonal contraception. I think maybe it is. So
I don't think it is, but I mean, if you say a nutrient, I feel like most nutrients, again, get affected.
Well, here, I'll put a pin in that. I'll come back to that in a second. Right. But the point is that there might be medications or dietary factors or things like low stomach acid or inadequate bile flow or enzyme capacity. Like there's so many things that could give the illusion of malabsorption, but it's really maldigestion. Or like in the case of hormonal birth control, I don't know if it's actually decreasing your absorption of the nutrients. I think it's more that what it does in the body, it's making you blow through those nutrients much more quickly, so you have an increased need for them with some medication. So I find a lot of people, like I said, like 80% of people come to me assuming that they have malabsorption, they're convinced that they have it, and then we end up kind of picking this apart and figuring out, oh, you don't. It's actually not very common to have malabsorption with IBS or SIBO. Crohn's, yes. Celiac disease that's poorly managed, yes. Colitis, you don't really absorb much of anything in the colon aside from water, so malabsorption is less of an issue with colitis.
Right.
But Crohn's and celiac disease, huge.
Yeah, and it makes sense though, right? Because there's so much inflammation in the tissue that leads to an absorption problem. What you're describing with the SIBO and IBS space is more of a digestive capacity issue. So you can support those things and they're still able to absorb food. So you can still take HCl or enzymes that help you break down the food and you're able to absorb that because there's not a degree of inflammation that's present like with Crohn's or celiac. Yeah,
exactly. Again, it's. I would say the difference is maldigestion versus malabsorption.
Right.
Or, like I said, an increased need for nutrients versus a normal person. And I'm just going to flip through here. I'll have you entertain the folks at home for a moment on your own, if I may, because I'm pulling out...
Oh my gosh.
One of these two will have the answer to the iron question while we're on that topic. So,
well, and I think the part of the problem may be that a lot of people in the IBS and SIBO space don't really understand the distinction between maldigestion and malabsorption. So maybe what they're describing too, they're not absorbing things, sort of in their mind is encompassing a maldigestion problem. But I think you're dead on with your analysis that, you know, these things are going to be way more common in a celiac Crohn's type patient versus you know, a SIBO IBS patient. And I still think you should do some calorie analysis. If you're someone that's losing weight, looking at calories I think is really helpful. Because a lot of people I've talked to are like, I don't understand why I'm losing weight, and we look at their calories and they're low. I think especially in women, more so than men.
I think fatigue, too. A lot of people who are fatigued and run down, they're not eating enough calories, and that's part of why they're fatigued. I've seen that as well.
Right, like the SIBO and the IBS is not the main driver of the fatigue. The not getting enough nutrition is the driver of the fatigue, but that gets lost in the sauce.
Yeah, exactly. By the way, I'm giving up hope on my effort to look this up right now. Just because the index is by name of drug, and when I tried to look up like birth control, it wasn't really coming up. So that means I need to know the name of the specific drug I'm looking at, and who's got time for that? If those of you, if anybody's curious about that, you can do a quick Google. I don't know. I tried to look it up for you, but I quickly realized the limitation of being able to do that. I'll share something else about Crohn's and colitis too, and then I actually have another thing that I want to cover about the potential connectedness between IBD and IBS and SIBO. But first, I also wanted to share, again, I pulled up some info just to share for today. I will point out also that ulcerative colitis affects men and women pretty equally, which is uncommon for an autoimmune disease. The vast, vast, vast majority of autoimmune diseases, Crohn's included, affect women way more than men. So that's something to know, but it's a 1-to-1 ratio for ulcerative colitis. And maybe not coincidentally, the other autoimmune disease that affects men not only equally, actually more frequently than women, is ankylosing spondylitis. And ankylosing spondylitis is associated with IBD. So it makes you think maybe the two of those are going together. So that, I think, would be worthy of people knowing. The other thing that was interesting that I saw in this little chart that I pulled up, there's, well, two things. Oral contraceptives do not appear to increase your risk of ulcerative colitis, but they do increase the risk of Crohn's, which is fascinating. Makes you wonder. But then there's just a couple of stats that I don't really have a lot more to flesh this out with. But the co-occurrence of ulcerative colitis and Crohn's in monozygotic twins, much higher in Crohn's. So it's 6% not comorbidity, what word am I looking for? Co-occurrence. 6% co-occurrence in ulcerative colitis between why is this a hard word? Twins, just twins, whatever, shut up.
Yeah.
6% for ulcerative colitis, 58% for Crohn's. So pretty big difference, which makes you wonder if there's a more strong genetic link with Crohn's. Again, kind of like the celiac gene, right? It doesn't do you to getting celiac disease, but maybe there are genes that influence how the immune system behaves or your responsiveness to stressors or mold or toxins or whatever. And then that makes some people a bit more vulnerable on a genetic level to some of these diseases. So it seems like that's more of a thing for Crohn's versus ulcerative colitis, which honestly, a lot more research is showing that ulcerative colitis, yes, it's autoimmune, but there's a very, very strong dysbiosis kind of component to ulcerative colitis, even more so than in Crohn's. And based on the location, that kind of makes sense, right? It's in the colon where most of the microbes live. Yeah. So I wanted to share those little tidbits.
Right. Well, and I think moving on, like you were saying, to like the SIBO, Crohn's, SIBO, ulcerative colitis, IBS type symptomology. And I think, again, maybe it comes down to like the environment in the small intestines. I think because there's such a high degree of inflammation, it definitely affects the nerves.
Yep.
Like it can affect the nerves in a much bigger way. And prevent the nerves from doing its job, and the nerves are what's responsible for digestion pretty much as a whole, digestion and motility. Yeah. So again, I think there's a big aspect of that, and I think if there's a lot of inflammation, it's also going to lead to more dysbiosis, and an inability to control microbe populations. Like there's a lot of things that within the gut environment that can help control microbes, and if you don't have that, if you have a lot of inflammation, it's a lot harder to do that.
That's a valid point. And I think that you're right. I think that the inflammation is a driving force for overall dysfunction or poor nerve conduction and that influencing motility. I think that that's a very real thing. Remember, too, that autoimmunity seems to be a SIBO root cause, which is ironic because then SIBO could be a root cause of autoimmunity, so which came first?
Right.
But those studies where they showed that people who were on thyroid replacement medications had a much higher risk of SIBO, even more strongly than some of the other risk factors, autoimmunity in and of itself seems to be a driving force for SIBO. And again, it's probably what you just said. It's that it's creating inflammation and dysfunction and poor nerve conduction, and then that zaps your motility, and then bada bing, bada boom. And you have this decreased ability to manage your microbial load, and then you're off to the races, and now you have autoimmunity and bacterial overgrowth, or whatever, candida, whatever it might be. I think also, particularly with Crohn's, if you think like the location in the small bowel, there's that localized, really hot inflammation in the small bowel, more commonly with Crohn's. More like, think of it as like leaky gut on steroids, right? Like it's just really wicked leaky gut. And if you have nutrient malabsorption as part of that picture with Crohn's, well, now you're going to have a hard time absorbing iron, which you need for motility and thyroid function. There goes your ability to digest your fat-soluble nutrients, vitamin A and vitamin D, which then help you make antimicrobial peptides and regulate inflammation. So there goes your critter control out the window with that. So it's like the autoimmunity and the inflammation, I think, can set the stage more so for SIBO in people with IBD, but then also like the nutrient malabsorption and the dysbiosis and the localized inflammation and leaky gut, like it's all kind of piling on. And to that point, the other thing that I wanted to share, thank you for leading right into that for me, was a paper, 2019, titled Systematic Review with Meta-Analysis, The Prevalence of Small Intestinal Bacterial Overgrowth and Inflammatory Bowel Disease. So somebody studied this. And they said, indeed, it was 11 studies, 1,175 adult patients with IBD, and 407 controls between those 11 studies. The proportion of SIBO in IBD patients was 22.3%. Let's see. I referenced this in a YouTube video a while back, so I think I parse it out I have one video on my YouTube channel right now about IBD. If you go to that one video, I parse it out a little bit more. I don't see it in the abstract, which one, like what the numbers broke down, but if I remember correctly, 22.3 was across both conditions. SIBO was quite a bit more prevalent with Crohn's specifically. I think it might have been the difference between like 30% and 15% for UC, if I remember correctly, but don't quote me on the numbers. You have to look at the study or watch that other video that I did on that. But the overall incidence between both diagnoses of IBD was 22.3%, which is definitely higher than the normal population. A lot of, when they have controlled trials of this, the normal population at large has like a 10% incidence of SIBO, give or take?
Yeah.
So it's definitely higher than normal baseline. And to that point, I have worked with people who have been diagnosed with Crohn's and IBS or colitis and IBS. Like somehow some people get both diagnoses, which is very fascinating.
Right.
Because usually we think of IBS as a diagnosis of exclusion. Like you check off Crohn's, you check off colitis, you check off celiac disease, and you're left with IBS. But I have worked with people who have received both diagnoses, which can be a little confusing unless you kind of parse it out and understand why.
Yeah, I agree. That is kind of weird. I would think the Crohn's would be the primary diagnosis of concern in terms of the conventional medical system, especially. In terms of, do we want to talk about like treatment at all, or like what if you get an IBD diagnosis, what would next steps be?
Yeah, I mean it's complicated for sure. So it's a little bit less clear of a protocol that we can give from this podcast, but I'll share. I'll just share a couple of things that I've seen before. I think that this is a group, and this really folds in beautifully with a couple episodes ago when we talked about, hey, maybe you should consider drugs. Right. This is a group that, again, we talked about, this is much higher stakes, much scarier stuff than run-of-the-mill IBS. It's not to say IBS is not miserable and awful, and I'm not belittling that at all, but the difference between a flare for IBS or SIBO versus a flare for IBD, way different. Like emergency surgery, possibly deadly, versus you're going to feel miserable. Those are two different things. So that being said, particularly if it's a fresh diagnosis or if it's really, really acute and aggravated and hot, I would really consider something like a biologic or an anti-inflammatory or a steroid, even if you're using it as a Band-Aid for a couple of weeks or a couple of months, just to get your feet under you and be able to make it through your day and function a little bit easier, and B, buy you enough time that you can start working with a functional doctor or a naturopath or whoever it might be and start building your team, getting some data, getting some understanding of what's going on. I think that it could be really, really important to buy yourself that time and kind of band-aid the symptoms so that you don't further aggravate and destroy the tissue and inflame your body. So I think this is a group of people where I would encourage you to be really open-minded to the thought of doing one of the anti-inflammatory drugs, even if it's for a short period of time. Ideally, it would be a short period of time, but this is a group where I would be very open-minded to that, for one. I think FMT...
Can I add one? Can I add one thought to that?
Uh-huh.
I think sometimes, like, the approach, like what you're saying, where people come to us and they want to do things naturally and they want to do things as naturally as possible. They don't want to be on meds. Yeah. And there's a time and place for meds, as we've talked about in that episode, and I think we're talking about now. But I think, again, I'm totally on board and with you with, you know, getting everything suppressed and before trying tons of different interventions. And I think, again, like the FMT thing that I was talking about before, they want people to be on steroids or anything that'll lower the inflammation and get them out of any flares before they do FMT. And there's a reason for that. FMT could be really helpful for them, but they don't want to be in any bit of a flare that's going to basically negate or even amplify the pathology. So I'm really glad you brought that up, because sometimes, no matter how much you want to do it naturally, it makes sense to do the drugs for a period of time just to calm things down.
Yeah, and that's the thing, is like it's not that drugs are bad. It's not that surgery is bad. And even, like, you know, you revealed in our last episode that you're pregnant. It's not even that C-sections are bad.
Right.
It's that it's the risk-benefit analysis, and it's the way that we kind of go into these things that I think matters a lot more.
Right.
Are you or your provider just slapping you on a pill or chopping out an organ or, you know, cutting you open like a fish in like a willy-nilly fashion and thinking that that's okay? Or are you doing everything reasonably within your power to do things safely or holistically or non-invasively first, and then you use that tool as kind of not a last-ditch resort, but like you reserve that for when it's really, really needed. Right? So, like, should all the people on planet Earth be on PPIs and cholesterol-lowering medications? No. Does conventional medicine do that anyway? Totally. But, like, is there a time and a place? Like, people who have cholesterol in the 500s that's, like, genetic and their family just makes boatloads of cholesterol? Sure, get them on one of those statins. Why not?
Right.
Somebody like my mom who had a geyser of a bleeding ulcer and needed a PPI for a while? Sure. Get her on it. It's not that they're bad. And I think it's admirable, and I think it's the right thing to try to do it naturally, but to a point. Like, don't make yourself suffer unnecessarily, or don't risk doing further damage to your body if it means that a drug might help pull you out of a flare more quickly or help kind of band-aid something. And like I said, buy you some time.
Right.
Like, even if you're literally like, oh my God, I just got diagnosed with colitis today. Holy shit, pun intended.
Right.
What do I do? Oh my God, my doctor said I need a drug, but I really want to do it naturally, but I've never been to see a naturopath or a functional doctor. That's fine. Take the steroid or the whatever.
Right.
And that way you have the time that you can start Googling and watching some videos or podcasts or whatever. You can start reading, you can start calling the offices, booking appointments, and building your team, and then you can start ordering some tests. Like, it can be a useful crutch to kind of get you to the next phase of your journey. So, for what it's worth. As far as natural things, probably the biggest diet template to maybe consider, again, with the caveat that don't restrict your diet unnecessarily if you don't really have to. I will share that it does, and I think I mentioned this in our hydrogen sulfide episode. It seems like the flavor of dysbiosis that happens with colitis, there's a little bit of research that's saying that there's more of a bend towards like hydrogen sulfide producers like Bilophila and Desulfovibrio. So I have seen some colitis patients do really, really well with a temporary reduction in sulfur in their diet.
Right.
I'm talking for like 2 weeks. Right. Just enough to pull them out of a flare, because you need sulfur to make a lot of things, including your mucus layer. You need sulfur to make glutathione. You need it to detoxify. Like, you need sulfur. It's not that sulfur is bad. But I have seen some colitis patients do really well just kind of pulling back on the high sulfur foods for a period of a week or two, help pull them out of a flare, and then they can start gradually reintroducing those foods over the course of the following week or two. So that's probably the biggest thing, you know, aside from, I think low FODMAP would have more chance of helping you if you also think you have SIBO. I think, you know, going gluten-free can sometimes help, not always, but these two conditions are autoimmune, so it might be worth trying out. Right. And both of them are going to need adequate calories and vitamins and minerals and fiber out the wazoo. You really want to emphasize fiber with both of these because, again, you need to feed those good microbes so you can crowd out the bad guys and get rid of them more quickly.
Right. Yeah, I think, again, there's probably going to be a nuance in every single case, because I feel like most of the issues for SIBO and IBS are still there. There's just, again, the major immune component in there that you have to kind of keep in check too. So again, you could still have like poor digestion, but you might have malabsorption on top of that. So again, it probably takes some nuance to figure out, you know, beyond what you're saying, what that particular individual's needs. But I'd imagine doing some immune support might be helpful too. Clearing
any pathogens, like that's always helpful. When your immune system is going bonkers with autoimmunity, it's trying to protect you from something. So helping to treat whatever the dysbiosis or the infection is always on the table. And I'll mention this briefly too. The poor people with microscopic colitis are like, what about us? You mentioned us at the beginning.
I know.
If you guys want us to do a whole episode on microscopic colitis, leave a comment on YouTube on this video and let us know, because otherwise we probably won't. Not for a while at least. But I will say there's some weird research on microscopic colitis. I shared it a few years back in one of those SIBO summits, I think. A bizarrely high number, like I'm talking like 60-70% of biopsies of the colon in people with microscopic colitis show either Epstein-Barr virus or cytomegalovirus in the colon tissue itself, which is weird stuff.
Right.
Normally, on like healthy controls, you don't see those viruses hanging out in the colon at all. They hang out in the either in B cells or the dorsal roots in the case of the chickenpox virus. But like herpes viruses usually have a specific reservoir that they like to hang out in. And for EBV and CMV, they usually hang out in the B cells themselves. Like they, ironically, and it's kind of like flipping us the bird, isn't it? The virus hunkers down in the cells of the immune system. It doesn't hang out in the colon or the pancreas or whatever. It just hunkers down in the B cells. So it's really weird that such a high amount of Epstein-Barr and cytomegalovirus is found in the colon tissue of people with microscopic colitis. It's wild. And I think that's across both. I think it's for both types of microscopic colitis, if I remember correctly. So I remember I shared that because I did a talk in one of those summits a few years back about the possible connectedness between like Epstein-Barr virus or viral infections and SIBO, and that was one of the things I talked about. I don't think, to clarify, I don't think it's a very common root cause for SIBO, so I wouldn't bother jumping down that rabbit hole for most people. But for microscopic colitis, it might be really worth your while to consider some antiviral herbs, like things like oregano, astragalus, some of the medicinal mushrooms, even supplements like monolaurin might be helpful because they're herpes viruses. And this is something too, I've only seen it one time, but on the GI map, they have the assessment for EBV and CMV in the stool sample. I've only seen it once, but it piqued my interest, and we started talking more about the possibility of microscopic colitis based off of that, because Likewise, it's atypical for those viruses to hang out in the colon. It's even weirder that they're hanging out in the stool samples. So that means the viruses, it was shedding. That person was actually actively shedding and replicating, even more so than somebody else might with microscopic colitis. So, pathogens broadly, I mean, I know we talk a lot about we talk about bacteria, parasites, and yeast predominantly, but there might even be a possibility that a viral infection or viral burden could instigate IBD in particular. So that's always on the table too. And this is where getting a little bit of testing under your belt, getting a bit more clarity and a workup would be really helpful. And then the other thing I want to share is just anything that you could do to help your microbiome be happier and healthier. Probiotics, prebiotics, that's going to go a long way, and anti-inflammatories. And I'm talking like high dose of all of these things. And I'll add, when I have situations like this where I want the anti-inflammatory action to take place in the digestive system primarily, like I don't care about the joints, I don't care about the brain, I don't care about the skin. I actually tell people, I'm like, I want you to go to Walmart and buy the cheapest turmeric and the cheapest resveratrol you can find, because we actually don't want it to be absorbed. So all of the fancy ones, with like the black pepper, and they're emulsified and in isolated, whatever it is, like all the fancy proprietary crap that you see going for like $80 or whatever on the internet, that's not what you want in this world. You want it to be poorly absorbed, so that way you're not getting it into your bloodstream. You're letting those anti-inflammatory molecules bathe your intestines all the way down. So I actually had people, I'm like, you could buy turmeric from the grocery store and just fill it up in capsules. You can go to Walmart and get the cheapest turmeric you can find. I don't care. Get the cheapo stuff, and we're going to load you up with really high doses of it because we want it to stay in the intestines and make it down to the colon, ultimately. So that's another little pro tip. And it's cheaper. Cool. It's cheaper than a lot of the products out there, so it's kind of a win in that way.
Yeah, for sure. All right.
Yeah. I think that's all I had on my radar. Again, this is a huge topic. We could do a whole episode on just colitis and a whole episode just on Crohn's. But at least for the primer right now, we'll give you guys this hell of a long primer, isn't it? An hour-long primer. But we'll at least leave you with this much. And keep in mind that you can have both IBD and IBS. It's not as common. You can certainly have IBD and SIBO. But that diagnosis of SIBO is going to be less common than it would be with somebody who's labeled with IBS. But I think that's all I had for IBD. How about you, Amy? That a wrap?
I can't think. That's a wrap. That's a wrap.
All right. Put a bow on it. Bam. And guys, like I said, if you want us to do an entire episode on microscopic colitis, or if you want us to do a breakdown of one about Crohn's, one about colitis, put it down in the comments, because otherwise we probably won't. We have a lot of great topics that are coming up, and we have a lot to share with you. So we'll probably put those on the back burner unless enough people comment and say, yes, please, more. But you know the drill. If you're on YouTube, you can comment down below. Also, subscribe to the channel so you know when we send out the next episode. Comment if you want to comment. Do all the things. And if you're on a audio-based podcasting platform, if you could rate this podcast 5 stars, that would be wonderful and amazing and so helpful. And that ultimately helps us reach more people and spread this news so that people can heal their guts, because that's the name of the game. I feel like it's been a little while since we've reminded people about our Instagram handles. So, Amy, care to share?
IBS.freedom.podcast, I believe.
Oh, well, I've kind of given up on that notion of
I know. We haven't.
Podcast.
My Instagram is Amy_Hollenkamp_RD.
Yep. And I'm Triangle Guts. So it's exactly what it sounds like. Guts plural. And we put out super cool stuff on the Instagram. But guys, until next time, we will see you on the next episode of the IBS Freedom Podcast. Thank you so much for tuning in, and we will see you so soon.